Okay, so can someone attempt this question? Can someone attempt?
This is not rate sign. Duodenal atresia. No, achalasia cardia.
Okay. Is anybody having a contrary view, opinion, or someone has something to say? Okay, you're right. This is achalasia cardia, and it's called the big sign, big sign, or the rat tail sign. That's the sign you see, rat tail sign. So this is a barium swallow of an individual with dilated proximal esophagus, collapsed distal esophagus, sorry, the dilated proximal esophagus, rat tail or bed big sign, and a distal collapsed esophagus. That's the definition. That's description. So diagnosis will be achalasia cardia. So what complications could arise with the development of achalasia cardia?
Pneumonia.
Okay, that's one.
Dysphagia.
Lung infections.
Lung infection, right? That's pneumonia, right? Okay, what else again? What else again?
Dysphagia.
The dysphagia is one of the symptoms that we have.
Okay.
Now we could
Perforation.
Yes, that's possible. Yeah. Well, let's try and reason out the complications. Because complications are not something you cram, you reason them out. Now, if the problem is with achalasia cardia is that food is unable to transit through the esophagus to the stomach, and then there's a classical presentation that differentiates it. Because achalasia cardia and esophageal strictures almost present similar in terms of history. Because if it's going to come out to your exam, that's how you differentiate them. Now, in achalasia cardia, they have problem with both liquid and solid, right? But they have the problem is more serious with liquid fluid, right? While in stricture, the problem is more serious with solid food. So that means a patient with achalasia cardia will tell you that when they eat something like a bar, but they'll feel discomfort, but after some time, the bar we go into they will not vomit it. However, for stricture, they'll tell you that they can take things like tea, things like drinks, but they cannot tolerate, or they find it difficult to tolerate things like eba, rice, and coal. So that is the singular most important history that tears both achalasia cardia and stricture apart from the history of causative factor. Once you hear this history, because in your MCQ, you could hear, if it comes out like this, and this is how you tear it apart. You get? So that is very important in identifying the diagnosis, right? Now, if food accumulates here because it cannot, if there's difficulty in progression, and what really causes achalasia cardia is because there's deficiency or absence of the muscle neurons, the mesenteric, Messner the mesenteric or the myenteric neuron and the myenteric neurons, which are those neurons found between the muscles of the gut, in this instance, the esophagus. So once neurons are, these neurons are essential for peristalsis. So when these neurons are absent, that segment for which the neurons are absent, we start having a peristalsis. Of course, peristalsis will move down here. When it cannot progress, it halts. And when it can progress, there's collapse of distance of the segment distal to it. And then food accumulates. But in solid food eventually will apply pressure on this distal segment, and subsequently some of them may trickle down. Hence, they usually will not have, initially they usually will not have problem with solid food. But then as it progresses, they will start with problem with both solid and liquid fluid and feeds rather. So that's one way to differentiate that, right? So when things accumulate here, liquid, food and co, and so the man lies down, that fluid can move into the trachea and then to the lungs. The patient can come down with recurrent lower respiratory tract infections such as pneumonia. And of course, when food, the esophagus, the gut lumen, particularly the esophagus lumen, is not built to have food particles on its surface for a very long time. Of course, when these food particles are there over a very long time, it causes epithelial changes because the epithelium must respond to that change, to those abnormal situations, and then it will lead to hyperplasia, and then it can be high risk of esophageal cancers from these patients. This is another complication the patient can have. Again, like she said, perforation, for some weird reason, this man can the solid food in the stomach can start causing pressure. If it stays too long, it can start causing pressure necrosis on the wall of the esophagus. Because again, like I told you, the esophagus is not built for storage. It's not like the stomach that's built for storage, or the rectum is built to temporarily store feces. It's just a passageway. So when food start accumulating on this esophagus, can start causing pressure, localized pressure on the wall of the esophagus, and then ischemia, and then there could be perforation coming from the esophagus. So these are some of the complications that the patient can have. So what three differentials can this be? Can someone ask them this?
Gastroesophageal reflux disease.
Okay, that's differentials. What else again?
Esophageal stricture.
That's correct. That's not differential. What else again?
Esophageal spasm.
Okay. Well, that can be a differential, but that's not the term they call it, right? It's not called sphere spasm. There's a term for it. What you are missing one, which I just described for you guys, so esophageal cancer can be a differential. So this is more differential. So how will you treat these patients? If they ask this question, well, for postgraduates, this is a big question. But for you guys, just 1, 2, 3, okay, you're good to go. How do you treat these patients? With answers.
Medications and surgery.
Okay, fine. So what medications could you introduce to this patient?
I think they give calcium channel blocker.
Correct. What else again? You could give nitrates. You could also give botulinum toxins. Those are medical therapy. Then you could also surgically, you could do serial dilatation with Buji. Then you could do absolute surgery where what they call cardiomyotomy. There's HELAS cardiomyotomy, there's HELAS. No, you don't need that information. What you just need, you can do surgery for the patient, or you can treat. And surgery, what you should know for the surgery is HELAS cardiomyotomy. Also, HELAS esophageal cardiomyotomy. HELAS esophageal cardiomyotomy. Or you could just say esophageal cardiomyotomy. That is surgery you do for the patient. There are different types, but you don't need that. Okay. Any question?
No. Thank you.
Okay, so we move to the next one.
No, please, the complications.
Okay, for the complications.
Yeah, you're talking about ischemia.
Huh?
And you mentioned ischemia. Ischemia.
I didn't say ischemia as a complication. I was trying to explain the complication of perforation. I said one of the complications that cause that. Now, food is accumulating, it's not moving, right? If this patient is lying down for whatever reason, the fluid could track down from the esophagus through the trachea to the lungs. So one complication the patient can have is recurrent lower respiratory tract infection, commonly pneumonia. So you could say pneumonia as one complication. You could see recurrent lower respiratory tract infection. That's one complication. And I said, again, I was trying to explain the complication. Complication are not something you cram, is you work it out. And I said, okay, look at this esophagus. The esophagus is a passageway. It's not being built for storage. So, but in this problem, in this achalasia cardia, the problem is that food cannot pass because there's absence of peristalsis in the segment. So the food then accumulates into esophagus, causing more storage capacity for those food. Now, what those food are there because the esophagus is not built for storage. The epithelial lining of the esophagus, like I said, is not built for storage. Those food there being there can then cause chemical changes, what we call conformational changes on the epithelial lining of the esophagus. And then that changes can be malignant transformation. It can become malignant. And I say one of the complications is also, another complication is esophageal cancer. And usually we ask commonly what type of cancer they usually have is squamous cell carcinoma. On that complication that occur again, like I said, the esophagus is not built for storage. If those food are there, it could start causing pressure effect on the esophageal wall where it's compressing. And when there's pressure effects, what do you have? There's decreased supply of blood to that compressed segment. And of course, when there's decreased supply to blood to that compressed segment, ischemia results. And if ischemia results, what do you have? Perforation. So another complication is perforation. Another complication a patient can also have again is that because food is not passing through this channel, patient is not able to get adequate nutrition. So this patient may have malnutrition. That's another complication. Another complication is that because food is not going out, as an food can get fermented in this place, and then patients are having bad breath, what we call halitosis. Those are complications we are talking about again. Are we okay?
Yeah, thank you, please.